right, hello everyone. My name is Iman Faja-Reddick. We are pleased that you could all join us for this week's lecture in Volume 8 of the KnowNeuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. We would like to thank our 2023 sponsors for their generous financial support of this series. Additionally, we are grateful to our International Neuropsychology Society colleagues for their sponsorship, and we wanted to share information about their upcoming conference. The theme for this year's INS conference is Culture and Connectivity, Neuropsychology Without Borders. It will be held in New York City from February 14th through 17th. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology and KnowNeuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to KnowNeuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now, it is my pleasure to introduce Dr. Robin Hilsebeck for today's lecture titled Cognitive Dysfunction Associated with Chronic Liver and Kidney Disease. Dr. Robin C. Hilsebeck is an associate professor of neurology at the University of Texas at Austin Dell Medical School and director of the Comprehensive Memory Center at UT Health Austin Mulva Clinic for the Neurosciences. She is board certified in clinical neuropsychology and also serves as the head of neuropsychology at Dell Medical School. Dr. Hilsebeck earned her doctorate in clinical psychology with a major area of study in neuropsychology from Louisiana State University. She completed an internship in clinical psychology with an emphasis in clinical neuropsychology at the University of Oklahoma Health Sciences Center and completed a 2-year postdoctoral fellowship in neuropsychology at the University of California, San Diego. Prior to joining Dell Medical School in April 2018, Dr. Hilsebeck worked for 5 years at a large global contract research organization, providing consultation and clinical surveillance for CNS clinical trials. And prior to that, she worked for 13 years in clinical, administrative, and academic research positions. Dr. Hilsebeck receives research funding from the National Institutes of Health, the Alzheimer's Association, and the Texas Alzheimer's Research and Care Consortium. She has over 80 publications and 180 workshop and conference presentations. She currently serves as the gender special editor for the Clinical Neuropsychologist and is on the editorial boards of the Archives of Clinical Neuropsychology, Neuropsychology Review, and the Clinical Neuropsychologist. She's a past president of the National Academy of Neuropsychology. We are incredibly excited to hear from you today, Dr. Hilsebeck. Thank you so much for being here, and the floor is all yours.
Thank you so much for that amazing introduction. I will pull up my slides. Oh, thank you. So let me get in presenter mode here. And I have to swap. All right. So I wanted to share with you all a little bit about how I became interested in chronic liver and kidney disease, and that was on my fellowship in San Diego. And I did a fellowship in hepatology right around the time the epidemic of hepatitis C happened. And it was fascinating, and I learned so much from the hepatologist I worked with, and we used to spar over whether the liver was more important than the brain. And of course, we all know the brain is the most important organ. But anyway, this is how I got interested, and I've been interested in this area ever since then. So today I want to cover the anatomy and function of the liver. We're going to talk a little bit more in detail about cirrhosis and its complications, and then the neuropathogenesis of why there might be cognitive dysfunction. Kidneys, same kind of flow. We'll talk about anatomy and function. In kidney disease, diabetes is the one we think about quite a bit. And then we'll talk about chronic kidney disease. What is that? How's that defined? And the pathophysiology. And I'll wrap up with kind of a summary about neuropsychological performance in these two chronic diseases. And I'm hoping by the time we're done today that you'd be able to talk about factors that influence cognitive functioning in people with cirrhosis and name 3 cognitive functions affected by chronic kidney disease. So here's your liver, and it is the largest internal organ that we have. It weighs about 3 to 4 pounds in most people. It's located in your upper right of your abdomen. You can see here. It's the only organ that can completely regenerate itself. And you can actually lose up to about 75% of liver cells before your liver starts to show signs that it's not functioning well. A little bit more about the anatomy, just to help facilitate our discussion. So the gross anatomy of the liver is pretty simple. It's all blood flows from the stomach intestine. It all has to flow through the liver. There are 2 primary sources that supply blood to the liver. So you can get some oxygenated blood from the hepatic artery, from the aorta, and then you get nutrient-rich blood from like the GI tract, the spleen, and the pancreas, and it flows through this portal vein here. All blood that passes through the liver goes out through the hepatic vein, which becomes very important when we talk about some of the complications. So the liver has over 500 functions. It's really complicated. And that's one of the reasons why artificial organ devices can't emulate all of them. And that's why we have to have liver transplantation. A real liver from someone is the only way that you will be able to survive. So I'll just talk at a high level about 4 main functions. Nutrient storage. So it stores and processes vitamins, glucose, iron, copper. Glucose, it will convert excess glucose into glycogen for storage. Iron, it processes hemoglobin. And copper, you might have heard of Wilson's disease. That's when copper is not eliminated well through the liver, and it accumulates there, and it can cause Wilson's disease. So that kind of goes into the next one, which is detoxification. So your liver cleans the blood by removing drugs, chemicals, toxins via the bile duct. But it's also really important in helping us resist infections. It produces immune factors, and it removes bacteria that way too. Another really important function is protein management. So the liver metabolizes, and it also synthesizes different proteins. So with metabolism, one thing you hear a lot about, it converts ammonia to urea, which is a waste product. We'll talk about ammonia a little bit more later, but it breaks down amino acids into different proteins, and it will help build muscles because it regulates all of these amino acids. And it's also important for blood clotting. And then digestion, it makes bile. Bile is what helps carry away waste and breaks down fats in our small intestine during digestion. The liver also absorbs fat, and it absorbs vitamins like, A, D, and it produces cholesterol, and it also produces special proteins that help carry fats through the body. So it's super complicated, which is why I would spar with my hepatology mentor. These are some of the most common etiologies of liver disease. You might have heard of alcohol abuse. That one's really common for neuropsychologists to see. And then what I mentioned before with hepatitis C virus, hepatitis B virus, there's a lot of different viruses. You may know about hepatitis A. There's like, I think they're through F and G now, maybe an H. So anything, hepatitis just means inflammation of the liver. So they just kind of number them. But these are the ones we see as neuropsychologists that affect the brain more. And then there's non-alcoholic fatty liver. And this is, some of you might have heard of non-alcoholic steatohepatitis. This is a subtype of non-alcoholic fatty liver. And basically, this has become much more prevalent because of the epidemic of diabetes and obesity. And the global prevalence of NAFLD in people with type 2 diabetes is 61%. And then the last one to mention briefly is cholestasis. And cholestasis is just when the bile duct the bile isn't able to be produced or flow well. The most common type of cholestasis is primary biliary cirrhosis. And this is kind of confusing because you don't have to have cirrhosis to have PBC, but this is where your bile duct is not, it's not allowing waste to be moved out through the liver. Here is a couple of pictures for you just to show you what a healthy liver looks like versus a cirrhotic liver. And then on the top left here, you can see, on the upper right here, you can see a nodule here. And I think maybe just to mention that a cirrhotic liver, as cells die, they form these nodules, which eventually become scar tissue. And scar tissue can't regenerate. So as long as you're in the nodule stage, there's a chance to reverse any damage. So this is healthy tissue with one liver here in the upper right. The middle one here, there you see more nodules along with some healthy tissue. And we're starting to get some, this is nodules starting to get some scarring. This is the blue. The bottom, you see many fibrosis tracts here, which is just lots of scarring. At this point, there's probably equal amounts of scar tissue and healthy tissue. This is when the liver's starting to have difficulty functioning. You might start to see some complications emerge. The Child-Turcotte-Pugh is a classification system, one of the most common ones that are used to define how severe liver disease and whether you're now into what they call chronic liver disease or end-stage liver disease. So here's the point scale. So these are the 5 things they look for, and you just kind of add up the points. So albumin, bilirubin, these are different protein indicators. Prothrombin time is how fast can your blood clot. Ascites, I'll show you a little bit more about that in a minute. So if you have 5 to 6, and this is hepatic encephalopathy, which we'll talk more about in a minute too. So you can see class A, if you have 5 to 6 points, you're considered class A, and then class B is 5 to 9, class C is 9. So if you're in class A or B of end-stage liver disease, you have a prognosis of about 70 to 80% survival over the next 5 years. Once you get into a class C, then you have a 50-50 survival rate over the next year. So it's really critical to catch people in these classes before they get to class C. And then we don't have time really today to talk about liver transplantation, but that's when these folks usually get placed on a liver transplant list. Here's ascites. This is the most common complication of cirrhosis. It's just a buildup of excessive fluid inside the abdominal cavity. This is a pretty extreme case. So if the liver can't make enough blood proteins, the fluid just kind of leaks out of the veins into the abdominal cavity. And it's often caused by like alcoholic hepatitis, any kind of chronic hepatitis, but it can also be caused by other things like congestive heart failure, cancer. So if that hepatic vein, remember I said everything has to leave the liver through the hepatic vein. If there's something that's closing that off, you can get ascites. And you treat it with low sodium diets and or diuretics. But if you get to this kind of severe stage, they have to do large volume periocentesis where they, take a needle and they draw out the fluid. And it's they go back from time to time to have that done. The other really common complication is portal hypertension. And this is when you have extremely high blood pressure in the portal vein, and it's usually caused by restricted blood flow. So what happens is those nodules or that scar tissues start to close off the portal vein so the blood can't flow. And then you start to get, your body's amazing. It's like, well, if we can't go through the portal vein, we're going to make our own vein. And you start to see these varices formed, and then they end up not even going through the liver or not going through as efficiently, and then the toxin in here to connect and help the blood flow through. So other causes of this portal hypertension besides liver scarring, you can have pancreatitis infection. There are other things that can cause this as well. But this portal hypertension is often a precipitant of hepatic encephalopathy. And so this is where neuropsychologists might be, especially if you work inpatient, might be called in. Somebody is possibly demonstrating what looks like an altered mental status. Really, hepatic encephalopathy is just a neuropsychiatric syndrome, and it's thought to be caused primarily from toxins in the blood that reach the brain because they don't get through the liver. They don't get filtered out. So this is one of the common ways to classify hepatic encephalopathy. And I'll not go into everything in detail today, but I want you to know about it. So type A just refers to acute liver failure. Like, for example, in drug overdose, when the liver completely shuts down, people become confused. Often acute liver failure is fatal. Type B is when people have portal hypertension that's caused from non-cirrhotic things like pancreatitis. And type C just refers to cirrhosis. So it's hepatic encephalopathy due to cirrhosis. And then you have levels of cognitive or mental status change. That's this grading right here. So MHE stands for minimal HE. So this is the scale they used. And this is minimal HE and grade 1 are covert, meaning they're not super obvious just by looking and talking to a patient. Like grade 0 or the MHE is similar to what we would call mild cognitive impairment. Unless you assess for it, you might miss it, and assess for it with neuropsychological testing. Grades 1 and 2, when you get there, is a little bit more obvious. You can see more attention lapses, can see some personality changes. It kind of looks like a early stages are really light delirium. And then grades 3 and 4, this is where we get overt here, where you know something's wrong. Grade 3 is actually when they require hospitalization. Usually this is, starting to get very, very somnolent. And then grade 4 is coma, and it's a really poor prognostic indicator. And you have to figure out what's causing it. Like, if it's due to portal hypertension, for example, or something else, and then or drug induced, then that's how you would treat it. You can lower, so since we think ammonia is one of the major culprits, the treatment is often trying to lower ammonia levels in the bloodstream. And you can do this with some medications like lactulose. You can do it through diet, but it's usually one of these things where it can recur, it can be persistent, but it's typically pretty episodic. So I want to use this slide to share with you more about the neuropsychological profile. And unfortunately, there's not a ton of, it's hard to do these studies. There's not a lot of neuropsychologists practicing specifically in this space. But I keep looking every year for more recent information, but this is still, I think, one of the better studies to highlight what the different grades of hepatic encephalopathy look like. So you have here the tests that they did. We have these folks who are in grade 1 hepatic encephalopathy. There were 12 of them. And then we had 23 in the minimal or grade 0 hepatic encephalopathy. And then we had 23 control participants. And there were significant differences here. Well, just to give you a sense, the average age is about 50. And what you can see here, if we just look at minimal HE for a second, people with grade 1 perform significantly worse on the visual matrices. The higher score is better. These are raw scores. And on trail making test, a lot of us know this is in seconds, and 51 seconds is, pretty slow compared to controls here. But you can see a significantly slower in a grade 1 compared to minimal HE. Also, just reaction time is slower in our HE folks, grade 1 folks, and also digit span was significantly lower here. When you look at differences between minimal HE and controls, it's really just the ones that reach statistical significance is the digit symbol substitution test right here, and actually digit span. There's a lot of variability, so you can see some of this between the small sample sizes and the variability in patients. This may account for some of the reasons why some of these findings were statistically significant. So, but I also think it's worth pointing out that when it comes to learning and memory, they're not so far off, not super noticeably different as opposed to the visual, motor speed, attention tasks. So basically, as you progress from no hepatic encephalopathy to minimal, you start showing mild attentional difficulties, some psychomotor slowing, but by the time you reach stage 1 or grade 1, you're significantly slower, having significant problems paying attention, difficulties with complex reasoning. And then, like I said before, like stage 2 starts to look like delirium. Stage 3 usually requires hospitalization, and stage 4 is coma. This is to give you a sense of what I mentioned with the course, episodic versus recurrent versus persistent. But I also wanted to show you what some MRI findings look like in people with cirrhosis and end-stage liver disease. So this is a 52-year-old woman, and this is kind of her baseline. These are MRI T2 flare images. She had cryptogenic cirrhosis. Back in the day, cryptogenic just meant they didn't know what the cause was, and later they thought that she probably had non-alcoholic steatohepatitis. But in the top row, you can see her scan when she's at fairly stable, but she did have minimal HE. And then during the following years, she kind of had several bouts, like she'd have a flare-up, she'd have over HE, and then she developed some chronic dysarthria during the time and some mild cognitive impairment. And during, when they thought she was around grade 3, she was hospitalized. They did a scan, and you can see the significant amount of white matter changes. Now, what's really striking, I think, here is 1 month later, at this point, she's recovered a little bit. She's still got some encephalopathy, but she's at a grade 1. You can visually see that there's improvement here in the amount of white matter hyperintensities. So there does seem to be some changes in white matter lesions that correspond to the level of hepatic encephalopathy and the cognitive impairment that you can see. And it's just a nice illustration of the kind of fluctuating course this can have. And it brings us into the, what is going on? What is causing these changes? And oh my goodness, it's so complicated and not well understood. So really the big picture of things to come away with. Brain swelling is one of the key factors that everyone agrees on. Astrocyte swelling causing edema, but also oxidative stress. And that's related to like increased ammonia levels, and also other precipitating factors. And you can see here, there's several different things that can precipitate an episode of hepatic encephalopathy. I think it's important to note that any one of these can be happening, or a combination of them can be happening at one time. When I was, my fellowship, and I'd be on call, and always during Thanksgiving holiday, people would have a flare-up or a bout of hepatic encephalopathy because they ate a bunch of turkey. And believe it or not, if your liver's not functioning well, just eating too much, they would end up in the hospital because they had too much protein, and their liver just cannot break the protein down. So one of the reasons why ammonia builds up in the bloodstream is because when you break down protein, one of the products is ammonia. And liver disease is not able to, when you have liver disease, you're not able to break this down efficiently and pass things efficiently. And then you get this buildup of ammonia in the system. And yeah, so in addition to like breaking down the protein, and the ammonia is available and it's not being moved out of the liver or processed properly, you have intestinal bacteria that produce ammonia. That's just part of what they do. And that doesn't, so there are multiple ways that you can have buildup of ammonia, and your liver just isn't able to convert it into urea, which is the waste product. So it's just not able to metabolize and synthesize at the same rate anymore. So yeah, that is one of the main factors, and it's very difficult to study very well in these patients. So I'm going to shift now to kidney disease. We already talked a little bit about how there's a relationship because the liver breaks down all the waste products, and it's actually, most of it is excreted through the bile ducts and through the kidneys. So now let's talk about the kidneys. So let's talk about the basic anatomy of kidneys. And you can, kidneys are about 5 inches long, 3 inches wide. You can see here's a couple of different cartoons of them. The left one is slightly longer and thinner, and the right one's slightly lower, and that's thought to be because of the placement of the liver. The kidneys receive about 20% of the total cardiac output of blood. So like more than 4 cups of blood per minute goes to your kidneys. And each kidney has a renal artery that supplies it. So very, very important to know about the blood pumping through your kidneys at that rate. So the primary function of your kidneys is to eliminate waste and toxins. And the functional unit of the kidney is the nephron, and it's made up of a few different things, but one of them is the glomerular, I have a hard time saying that word. Glomerulus, yes, that's it. So that's why we use the GFR as one of the indicators of how well your kidney is functioning. So GFR and creatinine clearance are just ways to help us know how is your kidney functioning. And it also is important to realize that creatinine clearance is also dependent on muscle bulk and your diet. So just to give you a sense of things, creatinine can change as much as 30% after you eat a bunch of red meat. So you have to kind of keep that in mind. But these are important indicators, all of them. Creatinine, serum creatinine is kind of an indicator of later renal impairment. So, but your kidneys are pretty resilient as well, and you can sometimes have a decrease in about 50% before you'll see in kidney function before you see a rise in serum creatinine. So for that reason, we use multiple measures to help us know if your kidney's functioning well, like the blood urea nitrogen. That's another indicator. So urea or BUN is formed in the liver as the end product of protein metabolism and the urea cycle, and about 85% of that urea is eliminated through the kidneys. So if it starts to be increased, then you realize maybe your kidneys are not able to excrete it, and it's kind of an earlier indicator of kidney function being a problem. And then albuminuria, it just refers to the abnormal presence of albumin in urine, which is another protein that the liver needs to break down. And once you see any amount of albumin in the blood, and you see it for more than 3 or 4 months, that is a sign that this person has chronic kidney disease. So let's shift gears for just a second and talk about diabetes, and then we'll come back to chronic kidney disease and cognitive functioning. So just to, diabetes type 1 is it's an autoimmune disease, and destruction of beta cells in the pancreas lead to loss of insulin secretion, whereas type 2 is more characterized by insulin resistance, and that's why your body it's not able to use insulin. The prevalence of both of these is increasing worldwide, but 90% is type 2. And about a third of people with type 2 diabetes will develop chronic kidney disease. So it's important to know about it. So for type 1, most commonly onset is around puberty. But the glycemic extremes, high or low, in these kids is associated with differences in cognitive and academic performance and reductions in brain volume. And if you have onset of type 1 diabetes under age 5, then your cognitive function is even more compromised. And just to give you a sense, youth with type 1 diabetes compared to controls have, on average, lower verbal IQ, worse academic performance, executive dysfunction, problems with visual spatial ability, and slower processing speed. And adults with type 1 diabetes are 5 times more likely to have lower scores on 2 or more cognitive measures if you use that cutoff of like 1.5 standard deviations. Effect sizes are smaller in adults than they are kids. In adults, it's thought that there's a genetic predisposition, probably environmental trigger, like you see with a lot of autoimmune diseases. And then there is data showing that slower processing speed worsens over time and is associated with development of things like retinopathy or neuropathy, showing that your diabetes is progressing and not as well controlled. And there is an increased risk of dementia in people with type 1 diabetes. It's in type 2 diabetes, usually this presents in middle-aged and older adults, although we are seeing an increase in youth just because of the obesity epidemic. The course tends to be more aggressive if the onset is in childhood. But 90% of people with type 2 diabetes are obese. So that's also part of the concern here. And the longer disease duration is associated with greater cognitive dysfunction. And then you have impairments in executive functioning, processing, speed, and memory. We do know that about 50% are more likely to experience cognitive decline, and it is a big risk factor for developing dementia as you get older. And I think sedentary lifestyle is a risk factor too, even in people with normal weight who have type 2 diabetes. Smoking also is a risk factor for cognitive impairment in people with type 2 diabetes. Small to moderate effect sizes in cognitive functioning in this population. So in the context of that, just to talk a little bit more about chronic kidney disease, prevalence is about 14%. Hypertension and diabetes are the most common causes. And 10 to 40% of people with chronic kidney disease do exhibit cognitive impairment. And people who require dialysis because their kidneys are failing, they're going to have the most cognitive impairment. This is the stage of chronic kidney disease and the GFR scale. And just to point out that I often in our practice with older adults see stage 3 chronic kidney disease as opposed to 4 and 5. A lot of times these folks are just busy trying to, stay alive, and worrying about their cognition is not top of mind. But we do see a lot of people in stage 3 kidney disease. So I am not going to spend a ton of time on the pathogenesis of what's going on. It's very complicated. I think anytime I see a slide like this, when you read these articles, there's hypotheses about it. There's hypotheses around vascular problems, the hypertension. There's oxidative stress. There's if you have malnutrition and you're also you're on dialysis, the natremia, there's also like the hemodialysis component. All of those things are contributing to cognitive impairment in these populations. So I'll just say, I don't know, nobody seems to know, but there are a lot of things that are possibly contributing. But what we can look for in our patients, if you're working with someone who has chronic kidney disease, so traditional risk factors are things you probably already think of when you're looking at most people. But it's with cognitive impairment. So hypertension, diabetes, are they smoking? All of these things are risk factors for cognitive impairment in someone with chronic kidney disease. Then, and these are areas for intervention. And then you get, specific to somebody with chronic kidney disease, they're dealing with all these other issues, arterial stiffness, just all of these things that are associated with having chronic kidney disease. And I want to spend a little bit of time on hemodialysis. I think it's really interesting. And so I'll talk more about that in a minute. This is just a snapshot of when you test, do a pretty comprehensive neuropsychological battery of someone with chronic kidney disease. About a third of the people have normal cognition, and about half of the people have moderately to severely impaired cognition. And it's small to moderate effect sizes. And then if you break it down a little bit more by hemodialysis, meaning who is having treatment, who is undergoing dialysis on a, it's usually a three times a week schedule. And so I'll orient you this to the different, orient you first. On the top, we're going to compare people with hemodialysis with different populations. And here you can see these are the cognitive domains we're looking at. So these are effect sizes, the mean difference. And down here you can see if it's worse in hemodialysis or worse in the general population. Yes, you probably already figured that out, that if you are on hemodialysis, your cognition is worse across the board, but it's, maybe 3/4 of a standard deviation from the mean here. And so just across the board. When you're comparing people on dialysis to people who have chronic kidney disease, it's kind of a, it's variable. Some things are a little bit worse in people in hemodialysis, and some things are a little bit worse in people who have chronic kidney disease who aren't on hemodialysis. And then to give you a sense of, okay, this is Parkinson's disease. What do people who are on getting chronic kidney dialysis, what do they look like compared to like a Parkinson's disease population? So for the most part, except for motor function and a little bit of the attention, yeah, if you're on hemodialysis, your cognition is worse than a lot of people on average with Parkinson's disease. So then you got to ask yourself, well, what if you're not getting dialysis, but you should? And I get this question a lot because I get questions about, should I come for testing and timing it with my dialysis treatment? When should I come to my testing? And it's absolutely, your cognition is worse if you're not if you're not having dialysis. So I usually tell them, don't come on the day because it's a long day, but definitely the day after is fine or whatever. We want you to have hemodialysis. It's life-saving and it's better for your cognition than to not have it. So just a summary of neuropsychological performance in both populations: attention and processing speed, executive functioning. These are the most affected in both of these conditions. We didn't go into transplant, but cognition typically improves after transplant because it's restoring the critical functions of these diseased organs. And in chronic kidney disease, it eliminates the need for dialysis, which has its own complications that can affect your cognition. And we didn't go into a ton of detail about that. But I do want to leave some time for questions. So I think I'll stop there and see if folks have questions.
Thank you, Dr. Hilsebeck. That was a wonderful presentation. Let me get some stuff situated here real quick. So with regards to some questions, one, I think this was a very important topic. I know for me in the peds world, I'm focusing a lot on these acquired and traumatic brain injuries. But I did have a patient recently that had a severe acquired toxic metabolic injury due to hemolytic uremic syndrome. So a really rare kidney disease, and just seeing the effect on the entire brain was pretty astonishing. So seeing subcortical structure impairment all the way to the brainstem as well. Patient went from DOC to, emerging, which is really exciting. But one of the questions that we have is, in terms of neuropsychology's role, you talked a little bit about the outpatient piece that you're doing as well. Can you talk a little bit about neuropsychology's role from the inpatient to the outpatient, how that changes, and what our services, the goal of our services are in those two different settings.
So specifically when let's just say somebody's inpatient, a lot of times the role of the neuropsychologist is to help the team understand, even if it's not a rehab setting, help the team understand what is the patient able to tolerate? Is the patient even understanding you? Like if you're in the middle of a encephalopathic process, you're kind of delirious. And so helping the team understand what the patient is capable of remembering or learning and how much support the patient needs is huge. When you're looking at liver and kidney patients, then it's about, sometimes it becomes about how quickly does this person need to be considered for transplant? Or can you tell us, do you think this is from the kidney disease, or is this like a dementia? Because for those of you who don't work in transplant, one of the contraindications for transplant is if you have dementia in older adults. Well, kids, this probably isn't the issue, but so like for an Alzheimer's disease differential rule out, is the cognitive disturbance something that we can help with the transplant? Because if it's not, the transplant is not going to help, it's not a good idea to do that. So some of those questions, and of course, transitioning to the outpatient, following up in encephalopathic patients, you can see improvement, and you can see how much support they might need after their hospital stay, and you need to engage family. Often discharge planning is huge, and this is any inpatient setting, helping understand what does the patient need, how safe are they, what supports do they need when they go home. So I hope that it's very similar across lots of diseases. I think it's the transplant piece that makes this group more, that's the unusual piece.
Can you speak a little bit to that in terms of when you are working through that differential diagnosis and that role of you're saying your data that's supporting for or not for advocating for the transplant for these patients?
Absolutely. It's a really tricky one too. The waxing and waning attention is really the key, because if somebody has dementia, then it's not about their attention waxing and waning like you see in a delirium or an encephalopathic process. So you can't necessarily say there's not dementia happening if they're encephalopathic, but you can at least say, right now this is something that could be related to this process. And then of course you gather the history from family and friends. It was an acute process. Like, was their memory fine before that? If it was, it probably isn't a gradual, slow neurodegenerative disease. This is an acute onset. Now we're seeing waxing and waning, which is a delirium or an encephalopathy. So it's really important to get the good history. Sometimes you can do assessments with them. Sometimes you can't. It depends on how they can tolerate it. But then, of course, our batteries tell us, as okay, are they able to encode the information? Do they, that whole, like, is there rapid forgetting of what they encoded, or is it a matter of it never got in but they retain what they learned initially? So looking at the pattern of performance as well, if they can tolerate testing.
That's so interesting. And I think just also highlights further the utility of neuropsychology in this patient population as well, that it may not come to mind right away. Another question that came up was related to that nice study that you had that was talking about pre-dialysis, post-dialysis. And you had mentioned that patients can come, like it's better for them to come in post-dialysis because that's going to be helpful for their cognition. You see that great improvement. Is there a certain time frame that positive effect is seen and that you like to see patients within?
I don't think there's a time frame, because when they are on dialysis, typically they have to go for the rest of their life. until they get a kidney transplant. But I do get the question about, well, do they come depending on when their timing is? I like to say if they're like on a Tuesday, Thursday, Saturday, or whatever, I'd like to see them on Monday, because then they have time to rest and not having the analytic effect or the up and down that you get with it right away. So as much time between their last dialysis, it's tricky to do that timing, but so I tell them.
Seems like a lot of variables to manage.
So many variables.
Yeah. The other piece that we had some questions about was just related to the white matter changes that you were highlighting, and how that's, you know, nicely related to the cognitive impairment that you're seeing in these patients. You had also mentioned memory as that can be impaired as well. Do you typically see that as an isolated memory impairment, or that most patients are on that dementia trajectory?
Typically, the memory is not one of the things that you see as much. So you see the attention and the executive dysfunction may be affecting their ability to encode, but like recall is usually, and recognition is usually okay. It depends on like etiologies and things too, but just in general.
Great. Well, those are the questions that we had for today. And again, we are so excited that you were able to share your knowledge with us. And thank you so much. And everyone, stick around for next week, where we'll have our next topic is on dementias.
Thank you.
Thank you.